I'm going to just give people maybe another minute, and then I'm going to do my introductions, acknowledgements, and then we will allow Dr. Chargot to start her talk. Okay, so it's 12:01. I'd like to get started. First, I'll introduce myself. Just visually, I am a middle-aged Asian American woman wearing teal glasses and sitting with a floral print behind me. And I've been told that my glasses match my picture. And my name is Justine Wu, she, her pronouns. I am a family physician here at the University of Michigan and a researcher who really is interested in using mixed methods to understand health equity and reproductive health issues. So I want to welcome you to the final 2023 webinar in this year's MDisabilities Provider Webinar Series. Today's topic is Palliative Care and Hospice Considerations for Patients with Disabilities, presented by Dr. Jane Chargot, who I will introduce in a second. This webinar is being recorded and will be available through the email to all attendees. Throughout the discussion, please go ahead and use the Q&A box for questions, and I will be tracking these and we'll address them at the appropriate time. But before we get started, we have to acknowledge that without the generous support of our partners and donors, this would not have been possible today, particularly and including that these are free of charge and we have real-time captioning available. We're very grateful to the Center for Disability Health and Wellness and their collaboration with a large training center, the AHEAD-DC RRTC, a grant from the NIDLR, also known as the National Institute on Disability, Independent Living and Rehabilitation Research. And finally, we've generous contributions from the Robert J. Fisher, MD Family Medicine Fund, and our own Department of Family Medicine's giving as well. Finally, we want to thank Screenline Captioning for giving us real-time captioning interpreter services. So let's go ahead and introduce today's presenter, a colleague of mine whom I admire greatly. This is Dr. Jane Chargot. She completed her family medicine residency and hospice and palliative medicine fellowship here at the University of Michigan. She's now an assistant professor here. She is an active leader in our inpatient palliative care service. She provides full spectrum primary care through our family medicine outpatient services, including at the Briarwood Family Medicine Palliative Care Clinic. She teaches residents, fellows, medical students, and her colleagues about palliative care, and as she runs the Palliative Care Consult. She's also a really dedicated educator. Longitudinal medical student teaching is part of her other responsibilities. She's here to share her wisdom today about providing primary care to complex, chronically ill patients, providing palliative care to patients both in inpatient, outpatient settings and in the community, and really trying to increase our understanding of what palliative care means for the care we give our own patients, but also as being people and family members to our loved ones. So please go ahead and help me welcome Dr. Jane Chargot. And if you want to go ahead, Dr. Chargot, and share your slides and take over.
All right. Thank you for that wonderful introduction, Justine. I really appreciate it. And thank you everybody for being here today. And I'm really excited to share this topic with everybody. So my discussion today is going to focus on hospice and palliative care for patients who are living with disabilities. I have no disclosures to discuss today.
Dr. Chargot, I'm so sorry to interrupt you.
Yes.
You want to do the display settings to switch? We're currently seeing your presenter view.
Did I do it again? All right, hold on one second. There we go. How's that?
Try it again. Thanks for noticing that, Dr. James. Are you on 2 monitors?
I am.
Okay. So you may have to switch monitors, and the other thing you could do is just unplug the monitor.
Okay, 1 second. Let me see if we can. I am so sorry, guys.
It's okay.
Let me try this again. How is
That looks
this?
lovely. There we go.
Great. Okay, excellent. Sorry. And thank you guys. Thank you for pointing that out. Okay, so let me go back here. Here are my objectives for today. I'm going to briefly go over them and then we'll move into our discussion. So we're going to start with just a brief overview of palliative care and hospice, because I think I want to make sure that everybody is on the same page and has a good baseline knowledge of the differences between the two. The second thing is to discuss barriers to palliative care for patients who are living with disabilities, and then palliative care considerations for that population, hospice care considerations for that population, and then some very specific, more complex cases that just should be considered in general. I also just want to say that most of our literature is very specific to the population of intellectual and developmental disabilities. And I am focusing a lot of this discussion on taking care of that population of patients who are living with disabilities. And I really also want to encourage questions from all of you for across the spectrum, and you don't have to focus in on them. And I just want to make sure that you guys that you are thinking about. So I wanted to start with this quotation from Dame Cicely Sanders. She is what I would call like the founding mother of hospice and palliative care. She's from the UK and really started what became hospice care out there, and it's transitioned to what we are doing now. So this quote, "You matter because you are you, and you matter to the end of your life. We will do all that we can, not only to help you die peacefully, but also to help you live until you die." And I think that really embodies what we hope to do in both palliative care, but also in hospice care. So palliative care, just to start off with a definition of what it is. This comes from the Center to Advance Palliative Care, which is one of the professional associations for palliative care here in the US. It is a specialized medical care for patients who are living with severe illnesses. It focuses on symptom management as well as the stress of living with a severe illness. And the goal is to help improve quality of life for the patient and for their family members. The care is really provided by an interdisciplinary team. By that, we mean doctors, APPs, nurses, social workers, pharmacists, chaplains, and many, many others. And it is appropriate to refer to us at any age and at any stage of serious illness. And it can be provided along with care that is focused on treating the disease and potentially even with curative intent. So I bring up this palliative care continuum timeline because I just want to say most people are really uncertain about the difference between palliative and hospice care. And they typically really align them as being exactly the same thing. And I really want to talk about what the differences are. So a timeline of palliative care involvement in an illness really starts at the very beginning of diagnosis. And it can span all the way until the end of that patient's life. But we really would like to encourage consideration of an early referral to help establish our understanding of who that patient is, who their caregivers are, what their needs are, and establish a really solid rapport with that patient and their caregivers. We then are more able and available to help intervene at times of need, for example, with progression of disease, worsening symptoms, anticipation of future decision points, and helping kind of navigate through those decision points. And if you look at this, that blue part in the middle, that blue square, really is when palliative care is best served. And you can really refer anybody at any time span from the time of diagnosis of a life-limiting disease all the way through until it's at its end stages. As patients really transition to that end stage disease and often may have limited or no further treatments that are available to them for their disease processes, that's when we often start to refer to hospice rather than palliative care in managing those patients and helping to explore what life looks like when we're moving away from life extending interventions, disease directed therapies, and more focusing on quality of life interventions. Additionally, something I just wanted to bring up here in this slide is that palliative care really is aware that when patients are coming into them, they're often already very debilitated at baseline or have baseline disabilities. And their functional restrictions might typically progress as their disease progresses. So our care is often already focused on trying to make this as accessible for these patients as they possibly can. We have utilized virtual visits for a very, very long time, longer than the pandemic. And on top of it, we often have home-based palliative care services that come to the patients wherever they are, whether they're in a home or whether they're living in a facility outside of the home. And so that brings us to the next question, what's hospice then? So hospice is when a patient has an expected lifespan or prognosis of 6 months or less, has opted out of or has no further options for life-extending treatment or disease-directed treatments, and has decided to focus their medical treatment on the goal of quality of life rather than the extension of life. So hospice can happen in a lot of different places. It can happen in home or at a facility. So when hospice is happening at home, the focus is really on quality of life and symptom management. The team consists of, again, a multidisciplinary team, typically a medical director who is a physician, and then APPs, nurses, home health aides, medical or social workers, chaplains, and often they additionally have other support services like music therapy, art therapy, massage, animal therapy, volunteers who come in to help with respite care for the patient's loved ones and caregivers. Typically, services in the home are more robust than we can usually offer outside of a hospital system or a facility system. So usually a nurse who comes by anywhere from 1 to 3 times a week, sometimes more often, if the symptoms need. A home health aide that's able to come by again 1 to 3 times a week for a few hours at a time to provide cares for the patient. And then support as needed by social workers and chaplains and all of those other support groups or support therapies. Hospice in the home is really free of charge. It's covered by all insurances, Medicare and Medicaid included. It covers all medicines, all the medications are delivered to the patient's houses to help decrease the access or improve the access that might be affected by patients' severe disease to those things. All durable medical equipment is covered. There are on-call services directly to their nursing group available 24/7. So in the middle of the night, if the patient has uncontrolled symptoms, they have a place to call. We call it the new 911, okay? And additionally, bereavement care for loved ones is extended from the time that the patient passes for at least 13 months afterwards, really recognizing that that year mark is a crucial timeline and often needs some extra support. And so we really try to focus on that as well. Some things kind of I alluded to, but some things that are often overlooked is that while hospice is able to provide a significant amount of care in the home, really the 24/7 care comes from the patient's loved ones and caregivers. And I think we really have to make sure that the care that's able to be provided in the home are things that those caregivers feel that they're up to, that they're able to do, and talk about what that might look like so that the patients and their loved ones have a good understanding of what this is going to entail. Now, hospice in a facility might look a little bit different. The biggest difference between the two is that the patient would be living inside of a, instead of at home, inside of a facility. And that facility would be then covering that 24/7 care. And that would shift those loved ones from being the patient's caregivers to now being their loved ones again, their husbands, their wives, their sisters, their mothers and fathers. You know, I think that transition is really important, especially if you've been a long-term caregiver for a patient, and knowing that as things change, perhaps some of that worry is lifted from you, some of that worry about inability to meet the caregiving needs might be off of your shoulders. And that might be a relief for a lot of families. Additionally, you know, there's often that worry that perhaps this isn't, that a patient may not want to die in the home. The family members may not want the patient to die in a home, and a facility is another good option for them. They continue to provide all of the same services there. So hospice would have oversight over the care that's being delivered to that patient wherever they're at. So they'll have additional nurses, home health aides, social work support, chaplain support, and other therapy supports coming into them in the facility as well. Another thing to know is that while hospice care itself is continued to be covered by insurance, the daily fees of room and board is not. And so this is often a barrier to this kind of care for some patients. The fees for living in a facility are quite high, typically somewhere between $300 and $700 a day. Medicaid does pay for room and board, but that often is another barrier to care for patients, and they have to find a qualifying bed. But this still remains a resource for patients in their end of life. So I wanted to take a minute to outline barriers to palliative care, and then we're going to discuss each of these points a little bit more in depth. The first one is access to care. The second one is provider education regarding palliative care as a resource for patients with disabilities. Communication barriers between the healthcare providers, loved ones, caregivers, and patients is a very big barrier to accessing palliative care. So the first one I just want to talk about is the actual physical access to care. So the first one is limited primary caregivers. I think this is an access point that's a huge burden and barrier to people across the board, but even more so for patients with disabilities. And then once patients are in the medical system, depending on where they live, they might have limited access to that specialized care that their baseline needs may require. They may be dependent on other people for transportation and to help arrange appointments. There are often significant communication barriers, and we're going to talk a lot about this in the next coming slides. And patients living with IDD and other disabilities are often incredibly isolated because of all of those factors we just talked about. And most often, their caregivers are their parents or their family members, and they're aging as well. And as they age, there may be further limitations to medical access and isolation. The next point is under referral and underutilization. So the first thing is patients are living longer with disabilities. Right now, they're basically at almost near parity lifespan expectations to the general population. And their leading causes of death are more typical: heart disease, cancer, chronic lung disease. But despite this, primary care and specialists have this experience in caring for patients that have these chronic diseases. But then when we add in patients with IDD and other disabilities, that group of patients continue to not be considered for palliative care at the same rate as when we compare them to the general population. And under-referral is really across the board. It's in our country and it's outside of this country. And the numbers really that I have been able to kind of find solid data points for are a lot of times in places that have universal health care. So specifically these two studies that I am quoting are coming from the UK and the Netherlands. The UK did an NHS survey data, and it showed that they were only referring 18% of patients who had IDD to palliative care. Even when they were in their end of life, they weren't getting referred to palliative care or hospice life. And I just wanted to point out that's the birthplace of hospice and palliative care, and simultaneously still having difficulty in getting consistent referrals. The second data point is a journal article from BMC Palliative Care Journal that reviewed these 10 major service groups that are from the Netherlands that provide resources for patients and their families and caregivers who are caring for patients with IDD. And when you look at the resources listed for these patients, only 15% of these service groups are listing palliative care as resources to consider when you are living with IDD. And then when they did more in-depth interviews on the actual healthcare providers who are listed within those resources, the indicators really show that across the board, these patients are still not being considered on an individual basis for palliative care and hospice care. So what are these things telling us? It's really telling us that the providers and general population are just really not educated about palliative care, and that there are barriers to referrals for this population of patients, even when the resources are available to them. And then in places where palliative care resources are scarce, they're even further under-resourced for these patients. So I broke down the communication barriers into two different sub texts. So the first one is really the barriers that come from the healthcare providers and the caregivers for these patients. So healthcare providers often assume that patients with disabilities, and specifically IDD, do not have autonomy over their own care. And even in patients who might not have legal capacity to be able to make decisions and have other decision makers in place for themselves, they can make their preferences known. And these preferences need to be heard, and they need to be taken into account when they are having decisions made for themselves in regards to their medical care. Healthcare providers often assume that the patients with IDD wouldn't understand concepts like sickness, health, death and dying, or recognize even their own changes in their own body. They often feel like if these concerns are raised to them, meaning to the patient, that it would bring distress, or it would scare them, and that it would be undue and they wouldn't understand. And so that they just don't raise those questions. They don't raise these worries to them. And that's not just for healthcare providers, that's also for the family and the caregivers. They often feel the same way, and they often resist having healthcare providers ask questions to the patient or talk about death and dying or changing healthcare status with the patient. And finally, there's a significant professional bias. Healthcare providers themselves, because they worry about talking to patients about potentially upsetting conversations, or they feel uncomfortable or feel otherwise barriered to just talking to the patient about their symptoms, they might overlook signs of distress or illness, and that leads to more advanced illness presentation at the time of diagnosis. And then, communication patient factors. This is incredibly complex area, and I really distilled it down to a couple things, but there's a lot here to talk about further, and this could be its own discussion. But patients with IDD often have very unconventional ways of expressing their distress. And these expressions can run the gamut. It can be withdrawal, it can be behavioral disturbances, crying, self-harm like hitting, biting, or pinching themselves, loss of interest in things that they really used to very much enjoy. And it can really be difficult to help elucidate the cause of this distress, and that really depends on the severity of the IDD for that patient. Patients are at baseline scared to ask questions of a serious nature to their healthcare provider. Patients without disabilities find this to be a very frightening space to be in. Patients with disabilities find that even more intimidating. And so patients who have mild to moderate IDD can still express these worries and concerns, but have a really hard time getting over that barrier of asking these questions. It takes time, it takes space, it takes the ability to have a situation that they feel comfortable and feel heard in. And if they feel like they're being dismissed, if they feel like they are not given the opportunity at one space or time, that next interaction is even going to be less likely for them to start to raise those worries or concerns. And finally, this is just a huge finally, there's so many alternative ways of communicating. Maybe they have devices that they use. Maybe they have interpreter needs. Maybe a patient speaks with through a tracheostomy and finds it very difficult to get their point across and finds it very frustrating, so just stops trying. There's so many places that there's a barrier in communication that palliative care can hopefully start to make a bridge. So what are some of the solutions that we have out there? These are big picture solutions, and then hopefully we'll come down to individual solutions. So big picture solutions: education for healthcare providers on what palliative care is and how it can help patients who are living with disabilities and severe chronic illness. Providing resources for caregivers and loved ones to help raise awareness and access to palliative care in the community. And protocols for palliative care referrals within institutions where patients are living, and to help them get better access and more regular access to palliative care. So how can patients help on the individual? How can palliative care help patients on an individual level? We can help enhance communication with patients, families, and caregivers. We can assist on advanced care planning. We can improve recognition and then address with care spiritual and psychological needs. We can assist the recognition of disease progression and recognition and changes in health status. We can help with complex symptom management. And we can help with resource coordination. And so I'm going to kind of dive into a couple of these. The first one is communication. So time is huge. In primary care world, I operate in both worlds, right? Palliative care and family medicine and primary care. I'm lucky to have 20 minutes with a patient in primary care. To be able to do all of these things the right way, we need to have time. And we need to have time to have patients come back and do this again and again and again. This isn't a one-time conversation. This is a long-term, ongoing conversation that's had. Number two, we can adjust to the communication needs of the patient. We hope to be able to start to develop our own understanding of the level of communication and the communication styles that these patients need and meet them where they're at. We often start to ask the patient, or if the patient can't really well define this, their caregivers, things like, what is a normal day like for you? What sorts of activities do you enjoy? What things make you upset? If you can't do XYZ thing, what does that mean for you? If they can't live at home, what would that mean? If they have to be in the hospital a lot, what would that mean? And even if the patient isn't able to verbalize their quality of life indicators. Caregivers can really help us understand with their own insights and give us a picture of those patients' preferences for their care. And again, just to say this out loud, avoiding language that undervalues their life, specifically like the word futile care comes to mind, really helping make sure that we're showing that we value and we feel that their lives are important and we need to take care of them. We can adapt and understand how the patient may interpret their changing medical needs. And adapt to changing pain and help them understand medical interventions. This one, I just want to say briefly, patients with IDD may interpret illness and discomfort possibly as a punishment or being their fault. And that can also be interpreted as these ways of expressing distress. And so it's often a good thing to keep this at the back of your head and see if there's ways that we can help alleviate that burden that they may be carrying. We can help the patient understand the reactions of those that they love around them, and particularly if those that they love around them are sad or upset. And so, you know, as somebody becomes more sick, the people who are caring for them may feel grief, may express that sadness, and the patient may not know how to really interpret that. And then again, may interpret that as being their fault or being a punishment or them harming other people. And so really trying to help them understand and reframing things in a place that they would be able to understand. And really being open to partnering with not only the patient, but the patient's caregivers, the people who are with them all the time, and really understanding that they are the front line. They are the ones who are going to be able to tell us, is there a behavior change? Are there other signs of distress? Did they have a good day? Did they have a bad day? How has the things that we've done helped them or hurt them? So really helping make sure that we are partnering, that we are doing this together as a team, and that we aren't the ones that are saying we're the boss. We're really just a cog in that wheel. So advanced care planning. You know, primary care doctors do this all the time, but a lot of times they're really limited by time, like we talked about before, as well as experience in doing this on a regular basis. So referral to palliative care early in the disease process can really, again, help overcome some of these barriers. Early referral really allows us palliative care providers to build that rapport, build that trust relationship, and then start to really understand what's important to that patient and start to help with advanced care planning. We can help establish decision makers, and we can allow for collaborative decision making. I just want to say again, and I'll say this many times, I'm sure, even if the patient does not have legal capacity to make decisions, their preferences that they're either voicing or demonstrating in their life needs to be taken into great consideration when making decisions. So sorry. When we establish decision makers, whether they have an established guardianship or if they have DPOAs who are making decisions for them when they are no longer able to, we need to make sure that that person is involved in these discussions. I can't tell you how many times I've seen discussions being had about somebody who doesn't have the ability to make their own medical decisions, but does not involve that decision maker. So number one thing is always make sure the decision maker is there. And then also the legal decision maker, but then also making sure that other people who are involved in that person's care who also participate in decision making are present during these discussions. And then, of course, the most important thing is to help make sure if the patient is able to participate in these discussions, they are there. And if they are not, revisiting what those preferences for care are and how we can help make sure that they are the ultimate place of reference for decisions. We also start talking about the burden of treatment and disease. These are questions that we have with advanced care planning across the board. It doesn't matter if you're living with a disability or not. But in patients who have this extra layer of need and needs for consideration, these are some of the questions that we really need to bring to the forefront. So, will treatments result in undue pain or suffering or fear? And can the patient understand why we're doing these things? Is this acceptable to them? Will they tolerate the treatments? What will quality of life be after a treatment? Are they going to have new functional deficits? Are they going to have sustained treatment side effects? Is the treatment going to change where effectively they're able to live at? How long will remission be sustained after a treatment is given? I'd like to say, is the juice worth the squeeze? Is this treatment going to be falling within the preferences of care for this patient? And finally, establishing appropriate documentation of all of these discussions. So that I will go through a document in a second that we can use on a regular basis, but these documents help establish the patient's preferences of care, resuscitation preferences, and considerations for possible expected complications of disease progression. So one of the many documents that we can use to help establish somebody's preferences of care is the 5 Wishes document. It's really been developed as an advanced care planning tool that is easy to read, it's easy for non-medical people to understand, and it's very gently worded so that if family members or caregivers are going through this with the patient on their own, they're really able to navigate through this in a very therapeutic way. So I will just say here is that at the University of Michigan and through our palliative care group, we do use this, but it is proprietary. And so patients themselves can order this off the internet and it comes in a PDF form and you can go through it. It has documentation in there for code status documentation that they can use to document with their physicians. And then it also will have establishment of durable power of attorney for healthcare. And it goes through the instructions and how we have to witness these things and notarize, et cetera. So all of those documents are within this, this tool. So chaplains and social workers are another huge part of our palliative care team. They're a group of skilled professionals that are trained in caring for those patients who have complex diseases and specialized needs. And I just want to say, I'm not representing our chaplains and our social workers with a photo of a dog. But what I want to note here is the more traditionally medically focused interventions are not the only important piece of palliative care. Addressing a patient's spiritual and psychological and intellectual needs are essential as they're moving through chronic life-limiting illness. And sometimes the best medicine from my inpatient team is not me coming in and recommending a medication or a pharmacologic intervention, but Anna, who is pictured here, Anna, our therapy dog, coming in and giving a good cuddle. And I can't tell you the way that somebody's face changes across the board. It doesn't matter if you're a child or if you're an adult. Stress, pain, distress, everything melts away when you're able to cuddle with a dog. So symptom management. This is one of our primary interventions when people think about quality of life very often is management of discomfort in the setting of complex chronic life-limiting disease. So it's crucial to make sure that we're involving the patient and the caregivers. And we've talked about this in communication, but really understanding how somebody is presenting. What does pain look like for you? What does other symptoms that this patient may have look like for you? We really try to focus in on the patient's comfort and dignity as we're going through this path with them. And we really try to be highly attuned to patients' changes in behavior. Some of the things that I have come across is patients rubbing their hands and their feet, and oftentimes will be an indicator for neuropathic pain. And maybe patients being more emotionally withdrawn, maybe because of symptoms, but also maybe because their bodies are changing and they're reflecting and they're going more inward rather than outward. And this can be a normal change in someone, but it may manifest differently on somebody who has intellectual and developmental disabilities. Unusual requests or actions may be reflecting changes that they're interpreting in their body, and their needs being reflected out in a little bit different than maybe we might anticipate. And kind of coming back to maybe not what is important to us, but what is important to the patient. What kind of things should we prioritize as we're trying to help them be more comfortable? For example, some patients really want to have very aggressive pain management. I really want to be comfortable as much as I possibly can. But some people really prioritize being able to be alert, to not be sedated. It might scare them. They may not like that side effect. And so trying to balance that comfort and alertness may be a huge priority for them. They may prefer to avoid hospitalizations or procedures, even those that might help them feel better, because of experiences or worry or being scared. And finally, making sure that we always keep our communication lines open, being humble, being able to partner with the patients and with their caregivers, the people who know them best. So I'm going to talk a little bit about quality of life here, and then also talk about a patient of mine. So the first thing is acknowledging our own, when I say our own, I mean healthcare providers' own personal bias, and try to avoid passing on our own judgments. You know, I know everybody here understands this, and I'm just going to put words to it, is having a disability is not a form of suffering. And those living without a disability must take care to not pass on our own bias and fears for our own future healthcare problems. Medicine has made huge progress over the past several decades. We can now ventilate patients in their homes. We can accommodate physical disabilities better than we've ever been able to. Patients routinely receive ICU level care inside of their homes, and sometimes for their entire lives. Response shift is really how we recalculate quality of life according to our own, the patient's own personal, individualized physical, psychological, and social being. What might have been a quality of life indicator before an illness may shift with time, may shift according to what has changed in our bodies and how our illness has progressed. And this is just really a reminder that while we have put through the effort to address advanced care planning, address preferences of care, it's really important to come back to that every once in a while. Is this still what you need? Has this changed for you? Where are we now that your body has changed? I want to share a patient story, and I obviously talked to this patient beforehand and got permission to share his story and share this clip I'm going to show you in a moment. So Tony, he has a progressive neurologic disease, and he was diagnosed shortly after birth. He has relied on his wheelchair since he was a toddler, and he's recently had his 30-year anniversary for his tracheostomy placement and his ventilator dependence. He has graduated from high school. He's written books. Most of those books focus on Detroit sports. And he's thoroughly enjoyed his close social relationships, his social media relationships, and going to sporting events. These past few years have been really difficult on him. The pandemic has hit him hard, and he's struggled with his own progression of disease. The fear of the consequences of contracting COVID has really limited his going back out into the community, engaging in those activities that he loves, seeing the people that he loves. And as the progression of his disease has continued, he's been less able to interact with people on social media and other ways that he could have that fulfilling social relationships. You know, he's transitioned his care over the past several months to focusing on staying outside of the hospital, focusing on his quality of life, and re-engaging in those activities that were previously thought of being too risky because of the pandemic. This has really given him and his family the permission to get back out there and enjoy life. And I just got a Christmas card today from him. He wrote it, dictated it to his mom, and she types it up. And he just said how this past year, and particularly these past few months, have been some of the best of his life. And I wanted to share this experience with you that he had over this past summer. And you might recognize some of the people that are in this video, and I confess that I had to ask my husband who these people were, but Lomas Brown is one of the head coach for the Lions, and he helped Tony here do something special. So here it is, and please let me know if you can't hear this. So every time I watch that, it just fills me with a lot of joy, and I hope that did for you too. And I want to use this as coming back to everybody's quality of life has different markers, and making sure that the markers that we use are those that the patient says and not the ones that we might put on them. So just kind of switching things, transitioning to hospice. When and how do we start to make that transition? So the first thing always is, does that patient's preference of care align with hospice? Are they wanting to transition away from traditional medical interventions, things that are focused on very specific disease markers, disease-directed treatments, life-prolonging care? Do they want to focus on quality of life? Do they want to avoid going back to the hospital? Do they find that going to doctor's appointments are more burdensome rather than helpful? And then also, does the patient's prognosis align with hospice? Do they have what you would estimate as their healthcare provider to be less than 6 months? So some of the considerations for hospice is, where does the patient and their caregivers want to be? Are there sufficient caregivers that remain at home? Are there sufficient caregivers for that patient to remain in the home? If they are changing locations outside of the home, how can we make it more comfortable for them? We really want to try and make sure that we're keeping the patient's care in a place and space where the patient feels the most comfortable, if at all possible. And is their location, if we're going to change it or if we're going to stay at home, accessible for their changing needs? And is their location accessible for their caregivers and loved ones? Is it going to be really far away? Is it going to be really hard for them to visit for a variety of reasons? You know, this one came into so much more of a light during the peak of the pandemic, when the thought of transitioning away from home meant that our loved ones weren't able to come and see them anymore. And that was a really big decision maker for a lot of people. And then finally, does the chosen hospice have the skills to be able to care for the patients with their needs? One of the important pieces to all of this is throughout the care on hospice is making sure that the caregivers have regular access to that legal decision maker. Sometimes that decision maker may be somebody who's not close by, and really making sure that there is easy access to them and facilitate that as much as we possibly can. So now I'm going to kind of focus on a couple special cases that really need a lot of nuance and thought processing as somebody is transitioning to hospice specifically. So the first one is when a patient has caregivers that are provided through insurance. Just thinking about the patient that I brought up, Tony and his family. Tony has Medicare waiver provided nurses. He's been approved for 24-hour care in the home by skilled nurses. When we transition to hospice, we're transitioning insurance coverage, and we cannot have home care provided by hospice at the same time that we're having home care provided by insurance. That means if we transition somebody like Tony to hospice, we are going to lose that 24-hour nursing care, and they're going to be stepped down in the level of care rather than stepped up. This is a very specific population. Most people have a step up in home care when they transition to hospice, but we want to be very careful with these patients because that recommendation to transition to hospice means that they may lose high level of care, and that is a huge burden to that patient's family and may really be a barrier to access to hospice. In the case of Tony, we are actually providing hospice type care. I am providing that for him, but with palliative care services, and that transition to hospice isn't going to happen until he is actively dying. The next one is chronically ventilated patients. So patients who are on chronic vents, if the reason that their end of life is approaching is not chronic respiratory failure, there really has to be and even if it is, there is a nuanced conversation that happens around how are we going to manage this ventilator, which is life support on somebody who has transitioned their focus of care away from life extending treatments to quality of life and hospice care. And so it really takes a lot of discussions, and we really have to involve the hospice team, the caregiving team, the doctors, and the patient to really discuss what is the goal of this, what are we hoping from all of this care, and what is the role for ventilation? Are we continuing it? Is it going to look different? What does this mean for this patient? I'm obviously not giving clear guidelines because it's individualized. It's across the board, completely different from every single patient. And then next data point is a couple different things. So tube feedings. Feeding a patient is a highly emotional place for families, loved ones, and caregivers to land. When patients aren't receiving oral nutrition and hydration, the decision to stop tube feedings and hydration through a tube is really hard for a family member and decision makers to work through. When we are able to feed and feed ourselves and to give ourselves our own fluids, we naturally, as we are dying, change our needs. We're not as hungry. We're not as thirsty. Small sips are enough to satiate ourselves. We may feel uncomfortable having a large meal. We may have aspiration. We might not be able to manage eating and drinking, and we naturally move away from it because our bodies don't need it. When somebody is getting this in another way, tube feedings and fluids, we have to pay attention to how the patient is reacting to this. Is their belly becoming more distended? Are they more uncomfortable? Are they having nausea and vomiting? Are they getting more swollen or edematous? Are they having difficulties breathing? All of these things need to be addressed with somebody who has chronic tube feedings so that the family and the patient and the hospice can all anticipate together what that plan of care is moving forward for this patient. Other life-extending treatments, and there's a gamut of them, but one that I might bring up is things like dialysis and other similar treatments where when somebody was doing fairly well, this was bringing them great benefit and helping extend their life. But as their bodies are dying, this may be less helpful. And going to something like dialysis may now be a bigger burden and more difficult for them, and now shift them away from good quality of life. So having a discussion about, do we continue dialysis? How long do we continue dialysis? Will hospice be able to accommodate dialysis? Because not all hospices can do that. This is a nuanced conversation that happens on an individual basis and really needs to be taken into account. Okay, so I want to open up and leave plenty of time for questions. So I'm hoping that that there are some of them out there for me.
Thank you so much, Dr. Chargot. I wanted to bring up one question that came up from Mahir Kakara. Is there a specific duration for which insurers usually cover palliative and hospice care? You know, I think the question here is, will they run out of coverage if you refer them too early?
Great question. There's not a, so if somebody like hits that six, okay, so that's two different questions, right? So palliative care is covered across the board. We are a consult service. So we are going to be just like going to see a cardiologist. So when you're getting disease-directed care and you're having a consultation with palliative care, that's covered by your insurance just like any other consult service. So there is no like definitive timeline for that. Moving into hospice, that's a little bit more nuanced. So you actually get reevaluated. You have that first, you know, and I apologize because it's been a long time since I've done frank hospice in a hospice care. And so I'm a little bit rusty on all of the exact timeline, but what basically happens is you get reevaluated at certain time periods. People can be on hospice much longer than 6 months. What really depends on is looking at how the progression of disease is happening for this particular patient. Are they still expected to have a prognosis of 6 months or less? And if so, then we just extend hospice a little bit longer and a little bit longer. And I've seen, and it's not unheard of, patients being on hospice for much longer than 6 months. However, in those, there are some patients that might actually get better by treating you like for quality of life. And there are some patients who may improve enough that their prognosis is no longer 6 months. And that is not insurance now. It is because this is hospice, and this is one of the two requirements, right? The family's and patient's preference and prognosis both at the same time.
Thank you. There's a question from Dr. McKee here, who is able to join in the middle, that educational resources around palliative and hospice care, because they're different, available for people with disabilities, if not plain language resources, say for people with limited English proficiency.
So there's all sorts. One of the places that I go to for a lot of those resources, gosh, there's all sorts. But CAPC is a place for education for healthcare professionals, but they also have a lot of resources for those healthcare professionals to pass on to patients. I also would lean into different societies and help. So one of my resources here, let me bring this up. The American Association on Intellectual and Developmental Disabilities has a statement on caring for patients at the end of life, and also has a fair amount of good resources available for that specific group. There are a ton of different resources that our social workers can accumulate, and they're from all over the place. But my group of social workers, if you're associated with Michigan Medicine and you're looking for those resources, please reach out to us because we can help you access those. And there's a ton of them.
Well, maybe we could send that link to the attendees if that's possible, Dawn. And we're at 1 o'clock, but could you really quickly in like 30 seconds touch on transitioning, just sort of pearls for transitioning from peds to adult care?
Oh, yes. Oh gosh. Okay, 30 seconds. There's a lot. So here at Michigan Medicine, we have pediatric palliative care and we have adult palliative care. We also have, through our pediatric program, a transitions of care group that's embedded within them that really helps facilitate those next steps. Now, it really depends on where that patient might be living, because Mott Hospital, they really bring in patients from all over the place. So depending on the team, that transition of care will look different. We really try, as they're transitioning to adult world, to get somebody local, because pediatric care for patients who have IDD and genetic conditions is often very, very specialized. And as they transition to adult care, most often they're transitioning to places that are more local to them. If they're around here, we have resources, but oftentimes they're really looking into leaning into things that are closer by for access. But transitions of care is a fraught place that some places do really well and some places don't. And some places have partnerships for transitions and making things go smoothly, and some places just don't. And it's fraught, it's difficult, and it's one of the most difficult spaces for families to navigate.
Thank you so much, Dr. Chargot. And I'm going to close here because we're 2 minutes just past the hour, and thank everybody for joining us today. Thank you so much, Dr. Chargot, for sharing your experience and wisdom.
Thank you so much. I hope that this was helpful, guys. Take care.